Next speaker is Ashraf Naga. He is one of our orthopedic and spinal traumatologists at San Francisco General Hospital. He'll be speaking with us about the initial management and operative indications for pediatric spinal trauma.
Yep. So thank you so much for the introduction and the invitation to speak. We have about 20 minutes to go through pediatric spine trauma, so we'll sort of focus on the salient features. It won't be a comprehensive talk, but we'll focus on those three things here. I have no disclosures. And this is the outline that we'll follow. We'll sort of first discuss the epidemiology. We'll talk about the anatomic and biomechanical differences that make treating the pediatric spine a little bit different than treating adult trauma. And then we'll talk about some of the nuances of the acute management, and then we'll delve into specific pediatric-specific injury patterns, followed by sort of technical considerations. So in terms of pediatric spine, pediatric trauma accounts for 5 to 10% of all spine injuries and a similar number of spinal cord injuries. So the only difference is sometimes these injuries are associated with higher mortality, and that's probably related to the additional energy that it takes to injure a more limber spine. The other thing that's important for us to recognize is injuries are commonly missed. So some studies report that 50% of injuries may be missed on the initial exam and evaluation. In terms of mechanisms of injury, the vast majority, so despite advances in seatbelt safety laws, the enforcement of drunk driving sort of laws, and advances in automotive engineering, motor vehicle collisions still account for the majority of these injuries. These are followed by falls, gunshot wounds, and sporting incidences. Further down on the list are non-accidental trauma, which we just need to have a high index of suspicion for. In these patients, the spinal cord injury tends to be masked by the accompanying traumatic brain injury, and birth trauma as well. And in terms of birth trauma, it's usually associated with hyperextension or breech position at the time of delivery. In terms of the mechanisms, there are differences between our younger patients, our children and our adolescents, with falls accounting for more of the injuries that we see in children, with adolescents having a distribution that's more similar to the adult population. The distribution of injuries within the spine are also different between young children and adolescents, and we'll sort of get into why that is. The biggest difference is the higher prevalence or incidence of upper cervical injuries in the very young. And all of these differences are really due to the anatomic differences. So especially in our younger patients, they have relatively underdeveloped neck muscles. They have more ligamentous laxity, which translates to more motion at a given motion segment, and a larger head to neck ratio. So there's just a greater moment of inertia on the spine. The vertebral bodies are smaller, and there's a larger disc height to vertebral body ratio owing to the non-ossified portion, and this translates to more motion at a given motion segment. So in the first couple years of life, the facets are a lot more horizontal. Typically, they start off at around 30 degrees. By age 8 to 10, they sort of increase to about 60 to 70 degrees. And so we also see that, and that's part of the reason why the pattern of injuries sort of shifts to more of an adult type distribution sort of around after age 8 or 10. Going back, so the horizontal nature of these facets really makes it so that the spine is more likely to translate horizontally in the setting of injury. In terms of the biomechanical differences, again, these are floppy heads initially, because children lack a mature lordotic curve, the fulcrum of flexion extension is at C2-3, and that slowly translates to sort of C5-6 by age 10. The big difference in treating the young spine is that it's growing, and it's growing because of the presence of growth plates. And we need to sort of have an understanding. Our interpretation of imaging really depends on our understanding of these ossification centers. So in the cervical spine, the posterior arch tends to ossify by 3 years, and then this fuses to the anterior vertebral body by age 7 or by age 5. The dens tends to fuse by age 7. And then the issue is sometimes, so these growth plates could be mistaken for trauma. but sometimes trauma is actually, these injuries actually happen through these synchondroses. So we just need to be able to pay close attention and really evaluate these patients. So our main treatment goals are to decompress what's compressed, to stabilize what's unstable, and to limit any growth disturbances and late deformity. In terms of the acute management, so our management starts off with an appropriate history and physical. We need to have a high index of suspicion of injury when patients have, based on high energy mechanisms, if they have accompanying head trauma, if they had any transient neurologic deficits, even if those were short-lived, and then any sort of multi-system trauma. In our pediatric population, we also need to sort of ask about any predisposing conditions that might lead to like ligamentous laxity or congenital cervical stenosis. In terms of immobilization, because of the larger head-to-body ratio, there are pediatric-specific spine boards that allow the head to rest back. These are not available in every system, so when they're not available to us, you could really build up an adult spine board so that the cervical spine rests in a neutral position. And this is really what we're trying to avoid. So this is a young kid where that wasn't done, and and this is sort of what happens, what we're concerned about, where in the setting of injury, we can inadvertently flex and compress the spinal cord. A neurologic examination in our very young patients, this is like admittedly incredibly difficult, so our sensitivities and specificities to pick up, minor deficits, especially in patients less than 3, is limited. Over the age of 3, you can get a better sense of sensory and motor exam, but a lot of times it's just limited to gross movement. But any sort of any deficit should warrant an evaluation. There are a couple, 3 big things that sort of mimic trauma. The first that we'll talk about is pseudosubluxation. This frequently happens at C2-3, and this is just relates to the laxity at that level. Normally, if we draw the posterior spinal laminar line between C1 and C3, the posterior ring of C2 should be within 1 millimeter of that line. If it's more than 2 millimeters anterior, that's concerning for an injury. If we see this in patients who are less than 8, we typically, it can be treated with a reduction in a halo. In patients who are older than 8, sometimes it's essentially like a flexion distraction type injury that might require fixation. In terms of the synchondroses, differentiating an injury through the synchondroses and just the normal development is sometimes difficult. But we'll get into that a little bit later. And then in the young, the normal appearance of the vertebral bodies on CT or plain radiographs tends to be wedged, and that's owing to the non-ossified nature of the bones. Okay, so we'll talk a little bit about specific injury patterns that are particular to our pediatric population. So our atlanto-occipital dissociations, these are devastating injuries. These are highly unstable. The mortality rates are upwards of 50%, and those go up if there's a delay in diagnosis. They're frequently accompanied by spinal cord injuries and really sometimes mixed pictures because the injuries are happening at the place where the nerves are decussating. So sometimes you can have sort of mixed patterns in terms of sensation and motor deficits that are not all on the same side. So any asymmetry of the occipital condyle joint is pathologic, until sort of proven otherwise. So this is from an adult picture, but the same holds in our pediatric population. The MRIs show a very significant soft tissue injury as well. These patients, because of the highly unstable nature of these injuries, these typically require, these are treated with a fusion to prevent recurrent cord injury. Going back to the initial management for these are essentially the injuries where these are distractive injuries, so sometimes the collar may actually exacerbate that. So this is one of my adult patients this is the injury CT scan, and you see you can see that the cervical collar is in place there on that scout and the OC joint is distracted. He went back down for another head CT a couple hours later after we had transitioned him to sandbags, and you could see that we no longer have that distraction. So for these are the patients that we typically put sandbags and immobilize that prevents other people from turning these patients inadvertently. In terms of dens fractures, so the dens you may have injuries either through the dens or through the synchondroses of C2. And so this is sort of what an injury may look like. So in children under the age of 8, these can typically be reduced. And if you're able to get them reduced, you can hold them in place in a halo for anywhere from 6 to 8 weeks. If these injuries aren't recognized, there's a thought that this may be a predisposing factor to os odontodium if it's not recognized. And this brings us to SCIWORA. This is, it was first described in the early 1980s as a spinal cord injury without radiographic abnormalities. And this was described in sort of like a pre-MRI era. And it was first described as the objective signs of myelopathy as a result of trauma in the absence of any obvious fracture or dislocation based on CT or radiographs. And this is thought to be, because of a flexion distraction mechanism where the cord gets caught between the posterior lamina and the anterior vertebral bodies in our young hypermobile patients. These account for 6% of pediatric trauma. 80% of these occur in children under the age of 9. Several studies in the throughout the 80s and the early 90s described worsening neurologic function that typically worsens with, either anywhere from 30 minutes to 4 days after injury, which really led to the recommendation of 12 weeks of bracing. In the current era, every patient any pediatric patient with a deficit receives an MRI. So on MRI, these are the things that we typically see in terms of structural issues that accompany these injuries. So rupture of the ALL, the PLL, intervertebral disc disruption, interspinal ligament tears, disruptions of the ligamentum or the tectorial membrane, and shearing of the growth plates. Now we cord injuries typically fall into one of 5 classes, so a complete cransection or a major cord hemorrhage. These are associated with a poor prognosis for recovery. Patients in whom we see only like a minor cord hemorrhage, 40% of those will improve to just mild grades, to mild deficits. In patients where there's only cord edema without hemorrhage, 75% will sort of be Asia Ds. And 25% will return to baseline. And in patients in which there was no sort of finding of edema within the MRI, those all tend to return to their baseline function. So early on, the recommendation was for 12 weeks of immobilization. But now there's been plenty of reviews that support the discontinuation of external immobilization, namely a collar, in patients who become asymptomatic and in whom we have confirmed stability with a flexion and extension radiographs. And we had a great talk right now on sort of clearance for activities. So, but regardless, if the MRI does pick up any unstable injuries, those are treated surgically regardless of the cord status. So these are our treatment goals. So we stabilize what's unstable, we decompress any ongoing compression, we try to prevent any further neurologic injuries, such as the case with the AODs. We limit growth disturbances and prevent late deformity. In terms of sort of technical considerations, so in placing a halo compared to the adult, we're using more pins, we're using less insertional torque. So we typically use 8 to 12 pins, sort of anterolaterally and posterolaterally. We avoid the supraorbital, supratrochlear nerves and the thin bone underneath the temporalis muscle. In terms of patients who were considering surgery, fusion is considered futile in the first year of life. And then in general, after pedicle screws, you can reliably put them in after the age of 4, but there are plenty of cases where you can, based on preoperative planning, you can put them in a little bit earlier if you need to. In terms of fixation considerations, it's really done on a case-by-case basis. You need to evaluate the size of the osseous corridors on CT. Consider the wiring techniques if you're not able to accommodate the screws based on implant availability. And think about the growth considerations. So in the very young, we tend not to do anterior fusions, so as not to tether them anteriorly, because that may predispose to late cervical kyphosis. In terms of patients who are undergoing operative intervention for their posterior C-spine, the course of the vertebral artery needs to be verified on either CT angio or MR angio. For my pediatric patients, I usually use the halo for head positioning as opposed to the Mayfield, which only relies on 3 pins in my adult populations. And patients with unstable injuries, we need to be careful in terms of how we intubate them so as not to inadvertently introduce another injury. In terms of instrumentation, so this is a paper that really looked at in the corridors that are available to us based on CT in patients ages 2 to 6, and this is looking to see whether we can safely accommodate a 3.5 millimeter screw. The occipital keel, the C1 lateral mass, and the C2 lamina all were able to accommodate 3-5 screws with a healthy margin. When we looked at either the PARS, when they looked at either the PARS corridor or the C2 pedicle corridor, those were only considered safe in 50% of corridors, and the C1, C2 transarticular pathway is only feasible in 4%. And so always, if you need to instrument C2, it keeps the C2 lamina option in mind. In terms of thoracolumbar trauma, so most of the other injuries that we've talked about were particular to the very young, but our apophyseal ring injuries we see those more so in our adolescents. They mimic a disc herniation. On CT, they may appear to be very minor, but on the MRI tends to show a larger sort of soft tissue component. And if patients remain symptomatic, then decompression would be beneficial. In terms of our bread and butter thoracolumbar injuries that we see, compression fractures are treated with conservative measures with pain control. In terms of our burst fractures, these are generally non-operative in the absence of any neurologic compression, and we consider surgery really only if there's any significant kyphosis or neural element compression. And these are cases in the pediatric population we'll consider instrumentation without fusion, with consideration of a hardware removal to regain those motion segments later. Our lap belt injuries, or our flexion distraction injuries, these tend to happen when you have a flexion distraction mechanism. The incidence of these has decreased with the use of booster seats, which lifts the child up so that the lap belt sits over the ASIS as opposed to the belly. And these lead to our chance and our chance variant fractures. So if someone presents with a chance fracture in our pediatric population, that's where it's without much displacement, you can treat those with a hyperextension brace. But if there's significant kyphosis, then these are generally operative and amenable to percutaneous treatment with a subsequent hardware removal. In the pediatric population, these typically happen at lower levels, so around L3, as opposed to the L1, L2s that we see in the adult population. So to summarize, the pediatric injury patterns that we see are related to the anatomy and the biomechanics of the growing spine. A thorough exam and a high suspicion is imperative, especially when we have patients that we can't get a reliable examination from. We need to understand the age-related anatomy, and operative intervention requires careful planning. So, thanks.